This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and it's my pleasure to have Theresa Ledrick with us tonight. Welcome, Theresa. Thank you. Now, you're a lady. You do a lot of different things, but one important thing you do is you're head of nursing. Is that correct? At the medical center on the neurosurgical floor.
Right. I'm the director of the neuroscience unit on 4 East and 5 East.
Well, that's a big deal, isn't it?
It is.
How many patients do you normally have under your custody there?
Well, we have 32 beds on 4 East, and we have 30 beds on 5 East.
Yes. So we work together a lot, do we
do.
not? I hope, am I a benign person to work with?
Very benign.
Pretty much good. All right, let's make sure everyone knows that. It's because this is really the central focus, I think, of patient care is the relationship that doctors have with nurses looking after their patients. And I mean, I think that many times the role that nurses play is neglected. People don't understand how important that is. Well, let's discuss a little bit about what happens on the neurosurgery service there. How many nurses actually service that floor?
We have 32 on 5 East and 33 on 4 East.
Wow, that's a big number. And they have to sort of go, do you have people on shifts, or how does that work?
We work 3 12-hour shifts.
Yes.
Three days a week. They go through a lot of training. The new nurses get at least 12 weeks of orientation.
Yes.
So that by the time they come out, they're comfortable with taking care of the neuro patients.
Well, why don't we discuss a little bit about what there are different kinds of nursing, I guess, degrees and how people do that. So we have LPNs, RNs. Maybe you could just talk a little about that.
We have LPNs, which we have 2 LPNs on 4 East.
Yes.
We have associate degree nurses, we have bachelor degree nurses, and we have a master degree.
Yes.
Who's the assistant director on 4 East.
And there are even some PhD nurses that are being
are.
hashed out. And so the idea is, I think nurses are playing an increasing role in healthcare delivery, and they have a very important role in this, I guess, general endeavor. Now, let's see, Theresa, you were telling me that at one time you considered a career in professional basketball. Is that right?
Right. That was back in the 1970s.
Were you a pretty good basketball player?
I was the tallest one on our team. I was a center.
Yes.
And this was back in high school, but it was 1975, 76, so it's a long time ago.
Now, were you in the half-court era, or did you play full court?
No, we played full court.
Well, all right. So that's you're a full court player, right? I can remember in high school, at least when I passed through, the girls were playing half court, but those days have long passed.
Right.
And so you thought about you were telling me earlier. Well, maybe professional basketball or police work. Is that right?
Yeah, I changed my mind quick.
You consider that, and then you've been married for 31 years, you tell me. Is that right? Well, that's great. What a good story. And you have some children?
I have 2 sons, Donnie, who is 30, and Justin, who's 28, and 2 grandchildren. I've got Christian, who's 3, and Chelsea's 6 weeks old.
Boy, that's a good story. So you have those children, and I'm going to just ask you a few other questions. And you attend a Baptist church in rural Wilkinson County. Is that right? Yeah.
In Ivy.
Ivy. Well, so you have, what's the name of that church?
Ivy Baptist.
Okay, good. And you've been a parishioner there for a long time.
Right.
Many years? Well, good. So you're obviously a very nice lady. Tell me about how you started your journey toward nursing.
I worked in a nursing home, and this little retired nurse kind of convinced me to go into nursing, and that was 31 years ago. I started out.
So how did she lure you into it? What did she say exactly?
She made me promise that the next time there was the test to get into school came available, I would do it, and it happened to be the next week.
Yes. Now you'd pretty well decided against professional basketball at that point, or is that still on your mind? Or?
I still love to play basketball.
Do you? Okay. Well, that's a good thing. You like to shoot those 3-pointers if you can do it. That's good. Well, so you took the test, and this was in Kentucky, or
right? It was in Louisville, Kentucky, and I went to LPN school there, and then I got married and moved to Georgia in 1980.
Yes.
And as of November 10th, I'll be at the medical center for 31 years.
Wow, so you've been there a long time. You've been there for a long time, 31 years. And have you had some more training as you passed along? You take some courses and.
I did. I went on back to get my associate degree in nursing in '94, and I just graduated last July with my bachelor's degree.
Well, that's great. You know, that's a real incentive for people. I mean, you're constantly trying to get additional education and take additional coursework. And did the hospital help you with that? I mean, were they understanding about this, and they had a program to do that?
They did. They helped with the tuition reimbursement, which right now is on hold, but I was able to get through and got mine paid for. But they also encourage you to go.
Yes.
And they work with my schedule. And whatever I needed, they made sure I got.
Well, that's a good thing. I think we've occasionally had discussions with different, I guess, nursing administrators, and that's just an extraordinarily valuable resource. I think there's a shortage of nurses, is there not? I mean,
There is, but it's not as much as it was.
Yes.
Now
yes.
we actually have hired to our fullest capacity on both floors.
Really? So, you know, I've heard as my wife is a nurse, I know something about this, but not a lot, but a little. And I think one of the big deals is the nursing schedule, how you work your shifts, and that can be a daunting thing, can it not? It's hard to have a family sometimes and do that. How does it work?
It is. We kind of do self-schedule, so we let the nurses kind of make their own schedules.
Yes.
So they know if they have doctor's appointments, if the kids have ball games.
Right.
And we try to work with their schedules and that. Some people still have to work weekends.
Yes.
So we have some who just work weekends, and that's by choice.
And they're 12-hour shifts, is that right?
Mm-hmm.
And what about night work? That's pretty daunting thing to do. It's people, you have to sometimes take a night call, is that?
You do, and I worked night shift for 9 years, and I like night shift.
Yes.
You don't have as much commotion going on. The patients are there. The doctors aren't, unless you call them.
Oh, is that good? Yes, you call them, they'll come in. Yes.
But night shift is a hard shift to work. But usually everybody does a rotation.
Yes.
And they start out on nights because they do have more time to learn and a slower pace.
Now, some of the things the nurses, we were discussing this a little bit earlier, is maybe you can describe what happens. There are obviously a lot of people out there that are checking into hospitals, and they're going to meet a nurse. So what happens when a new admission comes into the floor? What sort of interchange are you going to have? What's going to happen?
Well, once we get them in the computer, we have a long assessment that we have to do that covers their home medications, the things they come in the hospital with, their past medical history. And the assessment can take about an hour to do. Then you have to make sure you have the orders from the physician. If they come from surgery, they usually come with orders.
Yes. Now, when you have this interchange, does the patient express their fears, their anxieties? Do they sort of include you in their, I guess, they pay a lot of it. They have a major regard for wanting to communicate with you when they come in. Is that right?
They do, and their biggest concern is how they go get their pain under control.
Really?
So we teach them about their pain medication, about using the pain pump.
Yes.
And other measures as far as turning, repositioning.
Well, why don't you describe what a pain pump is?
A pain pump is a pump that we have that has usually morphine or Dilaudid in it. Mm-hmm. Patients can give themselves their own pain medication.
And what's the advantage, I guess, from a nursing point of view on that, and your experience with that? How is that work?
The advantage is a patient can keep medicating themselves. It's got a certain limit. I mean, they can't just overdose.
Can't overdo it, yes.
But the patients can kind of control their pain on their own.
Does that reassure patients a lot when they're facing this, or depends?
It does. It kind of makes them feel like they have a little bit of control over getting their medication.
So that's a substantial anxiety that people have as they face surgery, is just the postoperative pain.
Right.
And do you get to know the patients a little bit when this happens? Is that right?
You do, because there's sometimes that you just standing there and it's talking with them that kind of helps relieve their pain. Some anxiety.
Yes. You know, I've often thought that the nurses play such a crucial role in hospital care and generally care in general, in that the patients sometimes will communicate with them and sort of get their concerns, or a lot of times nurses have insights they share with doctors. Is that right, about what's going on with the patient?
It is, because we're there with them for the 12-hour shift, so we're in and out of the rooms frequently. And sometimes the patients will share things with us that they don't share with the doctors.
Yes.
And they feel like they can ask the nurse questions.
Yes.
Because we have more time to spend with them than the doctors do.
Well, that's a big concern, isn't it? I mean, just trying to, people are suddenly in this hospital environment, all these strange things are happening, and many times people are reassured when they get I guess a description from the nurse many times about what exactly is happening. Is that right?
It is, but they still like the doctor's input, and
Sure,
they
sure.
still go by what the doctor says.
And the problem is these doctors are rushed, aren't they? So I guess
Sometimes
that's just,
they are.
not always, but that's one of the things that happens in just the American healthcare system. There's so many things happening, you know, and I think that the communication issue is a big thing. Well, now, another thing that happens are when patients are discharged. Why don't you discuss that a little bit? So you play a central role in the patient's journey through the hospital. You're there to admit them, and also when they're discharged.
Right.
What happens then?
A lot of times the discharge can actually take up to about an hour.
Why does it take so long?
Well, if they have more than one physician, you have to keep checking with this physician. Like you might write an order saying can go if it's okay with the medical doctor.
Yes.
Then we have to get a hold of the medical doctor.
Right.
Then they give their discharge instructions. They have to have prescriptions written. Medications have to be verified.
Now, how are medications verified? What does that mean exactly?
We put the discharge medications in the computer. 2 nurses verify that yes, these are the correct medications the patient's going home
So
on.
you have to have 2 signatures
You have
there
to
on
have
that.
2
So it's a
signatures.
big deal about the medication. So it's a pretty complicated kind of interchange. In the old days, maybe a person would come through on 1 or 2 medicines, and here's the prescriptions, and things are far more complicated now because of medicine interaction, and many of these patients are on stupendous numbers of medicines, aren't they?
And most patients don't just have one doctor.
Yes.
They may have 2 or 3, 4 doctors.
Yes.
If it's pulmonary, renal,
Yes.
whatever. So we have to get verification from all those doctors. It's
Yes.
okay, and what education do we need to give them based on those physicians?
And many times this delays discharge, does it not? Just getting
It
all that
does.
put together. And I think one of the issues that goes on now is there's a major attention to diminish healthcare expenses and costs. So if people can get out of the hospital a little sooner, it's a tremendously positive event, but it's hard to get them out, isn't it, many times?
And what we're starting to do now is our night shift nurses, if they reading the progress notes that the patient may go home the next day,
Yes.
the night shift nurses will go ahead and start some of that paperwork to try to
Yes.
speed things
Right,
up.
right.
But they still can't go until the physician comes and discharges them.
Yes. Now, how about the amount of paperwork that you have to do? Is there a fair amount? Why don't you discuss the amount of paperwork that's in your normal day's activity, or a floor nurse? How much?
Most of our documentation is online, so most everything is done in the computer.
Yes.
But the computers, like everybody else's, can get slow, or
Well, do you type things in, or what?
you type things in, but you also have an assessment and that you just kind of check the boxes as you
So
go
you're
along.
checking boxes. Is that quicker than the old-fashioned way of writing in the chart?
It is. So you chart by exception. So if everything's normal, you just check the normal box and you move
Yes,
on down.
yes.
But then you have your medications that you have to
Yes.
verify constantly all day. Check for new orders.
Yes.
So you stay pretty much busy all day.
There's a lot of paperwork that goes on there,
There's
is
a lot of
there not? And so that may be one of the things about sort of visiting with a patient, or it makes it a little harder if you have all the paperwork. And how about vital signs? Why don't you just say what vital signs are and what the nurses do in regards to that?
Well, we do the blood pressure, temperature, pulse, and respirations every 4 hours.
Mm-hmm.
If it's a surgery patient, it's done every hour for the first couple hours.
Yes.
Because of the pain medication.
Yes.
If it's somebody who comes in with a brain bleed
Yes.
or craniotomy, we may do them every 2 hours.
Yes.
So we're constantly doing them, and I know patients don't like to be woken up at nighttime.
Yes.
But I always tease them and say, well, I don't want you to wake up dead.
Yes.
You know, we've got to check
Well,
these
we
things
wouldn't want
during the
that to
night.
happen on 4As, no.
No.
So there's a lot of just going into patients' rooms late at night and waking them up, and that patients don't like that much, do they? But
They don't, because they need the rest.
yes, and that can be a problem with the disordered sleep-wake cycle and that sort of thing. Well, let's see. And sometimes people have problems with, they just basically have a cardiac arrest, and the nurses play a frontline role in that. What happens when that occurs? What would happen?
The first nurse who, our techs
Are you going
really
to
good.
be an alarm that'll go off, or you'll just walk in the room, or how does that work?
Usually, we just happen to find them, or we can see based on vital signs or just the way the patient looks, kind of your gut feeling, something's not going on with this patient. And
Right.
so usually you're kind of aware that the patient may be crashing.
Yes.
What we kind of practice is you call a code, prevent a code. You don't wait for the patient to quit breathing.
Now, what is a code? Why don't you tell people what that is?
Code blue is a cardiac arrest or a respiratory arrest where the heart stops.
Do you push a button, or you just tell the...
We push a blue button, we holler.
There's a button to push.
There's a button in the room.
It's blue.
It's a blue
Does
button
every room have a blue button in it?
They do.
Well, that's something I didn't know. I guess I learned something. Where are these buttons located?
They're on the wall mount.
I'll have to remember that next time. So there are buttons in each patient's room.
Or I have picked up the phone and called the code blue myself from the phone. Just call the operator. We have a special number to call, and then they'll call overhead and alert the code team.
Well, I've occasionally done that. I just say, call a code. I say that, but apparently there's a button you can push. I hope I don't have to do that
But
too
even
often.
if the button is pushed, we still go to the room because we've had family members push that button.
Oh, really?
So we go to make sure.
Are the families aware these buttons are in the room?
Yeah.
You tell them that they're...
No, but they see them.
And then sometimes for the fun of it, someone pushes one of the buttons?
Sometimes a little kid may be in the room and they may start pushing buttons.
Yeah, that elicits a major response when a code... What happens when a code is called? I mean, everybody just swarms in there.
We have people from the pharmacy, respiratory, nursing, medical students, residents.
Yes.
Sometimes we have so many people in the room that we actually have to
That's
push
right.
people
I mean,
out.
it's not uncommon to have 25 people
Right.
and many times people can be salvaged. It's very dramatic event here when that occurs. You don't always have to call codes. What are some things that sometimes happens that you're involved in? Patients fall. What about preventing falls? That's a big deal, isn't it? You have many people that are sedated and they're old and fragile. What are the nurses doing to prevent that from happening?
Well, each day when you do your assessment, you do a fall score on the patient.
Really?
And based on what you assess at that time, they'll have a green armband on, they'll have a green sign on the door, green slipper socks, so that no matter where they go in the hospital, everybody knows that they're
If that's a person that's at risk of falling.
at risk of falling.
And so you're making a big effort to do that. Do patients sometimes topple out of bed? I mean, how is that prevented?
They do. We have bed alarms on our bed, so we can set the bed alarm on.
Well, let's discuss that. What exactly is a bed alarm?
It's the special beds we have. You set the alarm based on the patient's fall score. And if they're at risk of falling, we'll set the alarm. And it's got 3 different alarms. If the patient just sits up in the bed, it may alarm.
Yes.
If they swing around to the side of the bed, it alarms.
What happens if the alarm goes off? What occurs then?
It rings at the desk, and
Yes.
usually you have 3 or 4 people run to the room.
Yes.
And we prevented a lot of falls that way. We can't prevent them all,
Yes, yes.
but we do prevent a lot.
And so sometimes it happens, but that's you try and stop that. Well, you have fall alerts, and sometimes the patients wander away. What happens when a patient wanders away from the? Sometimes people can be a little demented or confused. Mm-hmm. What goes on with that? What do you do about that?
Well, and those are usually also on fall.
Yes.
We have their beds set for fall alarms. But we have had some wander out, and we'll call security, and they have cameras all around the hospital campus.
Oh, really? They do?
And they have spotted them out in smoking areas.
So one of the things that's going on when you're in some kind of hospital setting, any kind of hospital setting, there are cameras everywhere, aren't they? Just to kind of keep an eye on what goes on there. And that's for security issues, and almost anything could happen in a hospital environment, could it not?
Right.
So that's one of the things that occurs. Well, I mean, you've been at nursing, you've been doing this a long time. What do you think are some of the things that you've seen happen in your career that you'd like to remark about? How things have improved or gotten better, or?
A lot of, especially with the surgery patients, have really improved. When I first started, the myelogram patients came in the night before.
Yes.
Spent the night,
Right.
had the myelogram, spent that night.
Right.
Now they come in as outpatients.
Yes.
The lumbar fusions, they stayed in the bed for 2 weeks in
Right.
the hospital,
Yes.
went home for another 6 weeks in a hospital
Yes.
bed. Now we get them up the next day, walk them.
So that's a big thing. One of the things that's happening generally, and I think you could say the same thing about heart attacks or coronary patients. They've had a myocardial infarction. I think in the old days they'd be bedridden for huge lengths of time, and we're trying to restore people to the community and their family a lot quicker and not spend so much time in the hospital. So those are some things that are better. And can you think of some things that are not as good? Maybe you can't, but you might. What are some things that you can think that are?
Not really. I think everything we've done to improve things has made a huge difference.
Now, is there adequate staffing out there? I mean, you mentioned that there's a ratio that's observed with the number of nurses per, per patient. And what is that exactly? Can you talk about
Right,
that?
we've just kind of implemented, on one of the floors, it's a 4-to-1 ratio. One nurse will have no more than 4 patients. On the other one, it's like 1 to 4.5. And it's based on the acuity of the patients.
Yes.
Surgery patients have a higher acuity than medical patients.
Yes. Now, the nurses are constantly, you have your own culture, you're constantly trying to improve patient care, are you not?
Right.
So what are some things that happen? You have nursing rounds, or you have meetings, or what goes on? You're an integral part of trying to help patients and get them through the hospital and out in a healthy situation. What are some things that are done?
Well, we have daily huddles. So every morning and every evening before shift change, we have a huddle about what happened the shift before. So if patient's not doing well or patients fail or whatever, the oncoming shift is aware of what's going on.
Yes.
And any changes that comes through administration, we pass through emails or we have monthly staff meetings.
Yes, yes. So there's a lot of attention to making things work better. And so if something is amiss, then you contact the doctor, is that right?
Right.
And so over the years, those relationships, did you start out with one of the caps that people
I did.
Yes. I don't think people wear those anymore, do they? They
No.
don't have those caps again, yes. So it's sort of a different situation, but there's a lot of interchange. So you let the doctors know what's up, and they presumably are talking to you a lot about what's going on with the patient.
Right, and it's a trust that you have to build up with the doctors.
Yes.
So if I called you at 2 o'clock in the morning, you know that it was a serious
Sure,
issue.
absolutely.
We have had them call physicians for what was important to the patient, like a laxative or something in the middle of the night.
Well, I mean, it could
But
be
that was
important.
not-
Yes, right.
But I think it's just a trust between the doctors and nurses that
Right.
you have to build up.
So it's a big coordinated team. And would you encourage people to go into nursing? I mean, what do you think about it? Is that a good career? What are your opinions?
Yeah, I think it's a very good career, and there's so many opportunities, whether it's to the hospital, nursing,
Yes.
homes, schools,
Yes.
factories. There's always some kind of nursing jobs out there.
Yes, yes. Now, is there how do people wind up in a particular part of the hospital? I mean, you just assign, if you're a new graduate, how would you wind up on 4 East? Is there any particular?
Well, because we're a teaching hospital, we have a lot of schools of nursing come through. So as the students come through doing their clinicals,
Yes.
they sometimes find the area that they seem to think they want to
Yes,
work in.
yes.
Then we have the nurse extern program, so they can actually work as a nurse extern, and they actually work with the nurse, so they
Yes.
don't work as a tech.
Right, right.
And that kind of helps let them know if that's the area they want to work.
So are you an instructor? Do you tell the young nurses what to do, or you observe, or what goes on with that?
I'm usually out there with them. I try to be out there with them, kind of be a
Yes.
resource person,
Yes,
and still get my hands dirty with
yes.
them.
Are they timid, the new student nurses, or are they?
Some of them are,
Yes. Mm.
but we were
That
all
doesn't
there
last
once.
long, does it?
It doesn't. We were all there once, so we know how it is.
Yes. Well, let's see. We sometimes have adventures. What happens if there's a fire? And are you prepared for this? I mean, do you have like drills about different kinds of codes and what?
We do. We have the code safety, which we never know when that's going to come up, and we actually had a fire on 4 East.
Oh, did we?
Back in 1980s, I
Well,
guess.
I think I remember that. Someone was smoking in the
She was
room.
smoking in the-
That might have been my patient, actually.
No, I think it was one of your ex-partners.
One of my ex-partners' patients. They were smoking in the
She was
room.
smoking in there. She was confused, caught her bedspread on fire.
That's a bad idea to smoke. I mean, you can't really smoke in the hospital these days, can you?
No,
You're not
and
supposed to.
actually, you can't smoke even on the campus right
Yes,
now.
but people try and do that illegally. Do you see that sometimes?
We do, but now they go across the street, 2 blocks down, which is not safe.
They're out,
But-
it's that tobacco addiction, really. So people are out there trying to do this. Well, when the fire occurred, I mean, you push a button and everyone swarms in, and they do that.
You call us the 1600, you pull the fire alarm, and you start evacuating the patients. And they actually did that. They had all the patients lined up past the fire doors.
Yes. So one of the things that happens in a hospital environment, there's a lot of attention to almost anything happening. There are lots of different kinds of codes, aren't there? I think, is there like one of them, do you know some of the codes?
Well, code green means decontamination. Somebody came in, either gasoline on them, pepper spray.
Really?
And we have that. The code yellow, code orange. We have
Well,
all
why
different
don't we
colors.
just talk about some of the codes? What kind of codes do we have?
We have the code blue, which is cardiac arrest.
That's the most, that's the one that we hear the most
Right.
about, and that goes over the loudspeaker.
It does. The code green is decontamination. The code B is for bomb threat. We haven't had any of those in a long time.
No, but anything could happen, right?
Right. Code pink is for infant
Yes.
abduction. And
So we're ready for almost anything.
We're ready
Is
for
that
anything.
correct? Almost anything. That sort of rarely happens, but well, that's good. Now, what happens when we have it appears to me often what occurs is that the hospital just gets too full to accept patients. Is that a common story?
it is. We're working on some things with that, and they've just increased the ICU beds. We will now have, I think, 87 ICU beds through the hospital, so that will help a lot. And we're just working on the throughput, getting the patients in, getting the patients out.
Yes, because I think one of the things that happens in Georgia really is there's a limit to a hospital, the number of beds each individual hospital can have. So there's kind of a limit, and that puts additional stress on trying to make the system work a little better. Well, have you encountered any kind of thoughts about what might happen in the future with the healthcare issue? We maybe have some changes coming in with the new Obamacare or the new healthcare reform. Any thoughts about that? Have any ideas on that subject?
No, just the patients that are in the hospital are sicker, so they're staying
Yes.
there longer.
Do you think that's the case?
I think it's a lot.
So you mentioned earlier we're trying to get the patients out in a timely fashion. So one of the things that happens is, and we will have some more conversations in another venue about this, but very sick patients, it means that they have to stay there longer, and the way the compensation arrangements work for the hospital, they're sort of penalized. There's kind of this arcane formula out there, and if the hospital can't make its numbers, then it can't offer certain kind of services. And there are actually a fairly robust number of services that the patients receive on 4 East. I mean, can you name some of them? We have physical therapy, and what are some more things
We
that
have
go
the
on?
physical therapy, occupational therapy, speech therapy.
You can just keep naming them, can't
Right.
you? Yes. And so it's important, I think, to go through the rehabilitation issue. Now, isn't that a problem we often have? The patient is ready to leave, and we can't get the patient discharged. Is that correct?
Some of the problem with that is insurance. They have to wait for pre-cert from the insurance
Now, what exactly
companies.
is so we have a patient that is ready to leave the hospital, but the patient is being kept in an inappropriate environment in many ways by the insurance companies. What is a pre-cert exactly?
They have to certify saying, yes, we will pay for this patient to go. Some, it may be out of their network. Some may feel like it's not appropriate for rehab.
So in the meantime, the patient is somewhat, I could use this phrase, shipwrecked there, waiting for some kind of, I guess, appropriate new environment, and taking up a bed that's an important,
Right.
access to that bed's an important issue, isn't it?
And sometimes they'll go to like a swing bed,
Now,
nursing home kind of bed.
what is a swing bed?
It's at a nursing home, and part of it may be nursing home, part of it may be rehab.
Yes.
So they'll go to.
So this turns out to be a very complicated kind of arrangement. Is that right?
And sometimes they have to go home with the family who has to be taught how to take care of them.
Yes, yes. Now, when you manage these nurses, I mean, you're the generalissimo of these 30+ nurses. Is that a difficult job doing that? I mean, do you have a hard problem, or is that mostly the nurses are pretty easy to deal with?
Most of them are pretty easy to deal with because I've worked side by side with most of them.
Yes.
They also know they can come to my office anytime they want to, and it's open door, and
Yes.
come in and they can shut the door and scream and holler or
Yes. Do they
whatever.
do that?
Occasionally.
I hope they're not upset with the doctors, are they?
No, never.
Oh, good. Right. They're a very benign group here. Well, I think it's just been great having you here, and I think the public needs to realize that the whole healthcare system would not work without the kind consideration of people such as yourself. And I think you're a good role model for all those nurses that you help and manage and look after. So thank you so much for being here, and we'll have you back. Keep up the good work.
Thank you.
It's been nice to talk to you.